everybody. This is Dr. Ben Widmer. Born in Maine, grew up in Philadelphia, and clearly is still a diehard Eagles fan. Um, he graduated from the proud Ohio Wesleyan University, where he majored in zoology and English. Completed residency with myself, and I was proud to be his co-resident at the great University of Utah. Went on to complete a shoulder fellowship at UPenn, and currently sits as the medical director for shoulder surgery at Intermountain Health Musculoskeletal Clinic program. And so has a leadership role in a very large, I would say, health system. And so we're very lucky to have him this morning. Unofficially, great friend, great surgeon, and great educator. And so couldn't be happier, Ben, to have you with us.
So thank you for the introduction. And yeah, Matt and I were residents together a ways back, and Intermountain Healthcare is a big company and it's split into a few regions. So as Matt said, I'm the senior medical director for one of our regions, which we like to say and know is the largest of the three regions. So I do have to dabble outside of shoulder surgery now for some planning and some strategy, and it's all fun. So should we start with more clinical? Is that the way to go, do we think?
Yeah, I would start there.
Yeah, okay. All right, so let's get this going here. And so I'm going to share my screen, ideally without logging out here. It's not quite yet, sorry. Let's go. It's better to start the first slide. I think it's going to be better.
I'd love to say that I could help you, Ben, but I probably can't help you.
Yeah, that's fine. No, it's gonna be fine. I can tell you here. Okay, so I'm going to share this one, and then does that look like a talk?
Yes.
Perfect.
Okay. All right, very good. Okay. So again, thanks for having me. And I was just going to talk a little bit about reverse arthroplasty for fracture, and then move into some of the other sequelae that we see at times down the line, and just kind of make that a longer talk. So proximal humerus fractures are problematic, even in Utah, where everyone thinks everybody's healthy. Matt can attest that it's not always like the Olympic year and professional sports. We got plenty of people that fall down and smash their humeri that weren't skiing or weren't being super active with great bone and not smoking, stuff like that. So I'm not saying it's the same as what you have in Michigan, but we get plenty of fragility fractures. Most of these are in older patients, and I think they're the second most common fracture of the upper extremity, and I think we all see these every day. We're doing a lot of shoulder and sports medicine. So here's just kind of one little case. Maybe most of people on the call will see this in a few hours when you go to clinic. But kind of fall down, smash the humerus. So what do we think of? There we go. So indications. I mean, I wanted to talk a little bit historically. I don't think we're doing a ton of hemis anymore in our system. We can discuss more whether that's still very popular for either Sharif or Sardelli, but it is important, I think, to talk about where we've come from and what gets a hemi versus a reverse or potentially is fixable. So I think true four parts are problematic for sure. I think, if the head doesn't have reasonable blood supply, it's a worry. A bad three part, whatever that is, maybe that's a head split. Maybe that's thin or comminuted bone associated with the head fragment. So yeah, it's a three part, but you're worried about getting some screws into it. Maybe they had underlying early or maybe advanced cup arthropathy before they fell. And it's a 3-part, it looks fixable, but they have some arthritis and they don't have much in the way of cup. A key question for me is always, if I'm going to fix this, am I going to be able to make it look fairly reasonable so that down the line, if something happens, I can put either a reverse or an anatomic arthroplasty in. So if I can't recreate that anatomy reasonably with ORIF, I'm going to lean more towards arthroplasty. And let's not forget, if the anatomy looks reasonable as it is, let's do nothing. Put them in a sling, let the arm hang, and do some therapy. But that's not as much of a fun talk. So let's talk about surgery. So if you can recreate reasonable anatomy with ORIF, you think it'll heal, and the ORIF won't compromise future arthroplasty, I still think that's a very reasonable way to go. So just a couple options here, on the left side there, bad image, kind of, heavier patient, bad neck, and that person had some cup arthropathy. So you might say, maybe I'll get a CT scan. Maybe that's a 2-part. I don't know. But I think you're already thinking that even if you fix that, that person's going to still have a stiff, painful shoulder due to their underlying arthritis and cup dysfunction. On the right image there, you got a head split, probably going to get a CT scan. That may well be a 4-part as well. But those 2 images, for different reasons, I think are pushing you in the direction of not just fixing those. Okay. So Hemi, again, progressively less popular, probably, every year that I give this talk. And just as full disclosure, hemiarthroplasty for these types of fractures is my least common. I do think it helps us discuss where we come from, where we're going with arthroplasty, but Hemi is the least common for me, usually a younger patient. And non-op, ORIF, reverse are all much more common. So if you're going to take these patients for arthroplasty, your Hemi, and most people are familiar with these studies now, but your constant scores and your ASES scores tend to do better with reverse. Your revision surgery is more likely with the Hemi. Your tuberosity complications are a little bit more problematic. So you have worse outcomes with failure in a Hemi. Your tuberosities are not as likely to heal with a Hemi. And when you revise a Hemi to a reverse, that's not always as reliable as you think, even on a convertible platform, which we'll talk about in a little bit. It's not always straightforward as it seems unless you have a really modular metaphyseal portion on the implant, to convert to a reverse arthroplasty. So tuberosity malposition and non-union after Hemi are identified as significant risk of migration of the prosthesis with cup failure, stiffness, weakness, unsatisfactory results, persistent pain, etc. So here's one prior popular design. I don't use this as much anymore, but this was the cup. And some of you may have used this or still use it, but this allowed you to adjust the metaphysis. So the screw inferiorly here would screw into a stem. This is showing the cup for reverse arthroplasty. But the idea was that you could put a Hemi adapter and a head on this. Then if that failed, you could swap to this, or you could go to this out of the gate. This was the DePuy design for Unite with the suture collar here. Porous coating, adjustable version here, which I think at the time when that was designed was probably a little bit more important. There was a larger, I think, differentiation at the time between where people would place their retroversion for an anatomic arthroplasty and a reverse. I think in the intervening 10 or 12 years or so, I think more people are getting comfortable with a more anatomic or closer to a more anatomic version for both implants. But this is a great concept. It's still on the market and it still works well. You'll notice this was more of a 155. Again, maybe we're migrating away from that a little bit now as time goes on. But here, sorry, no animation, but just, person falls down, kind of blasted, heads most of the way off. And so this implant works great. This is the DePuy. So again, looks a little bit older, I think, style compared to what some of us are using more now. But still a great option with a more of a typical Grammont style. So as we worry about fixation of tuberosities or repositioning the shoulder, I think more and more people have started to talk about lateralization. What does that mean? Does that mean building up with bone on the prior implant I just showed, like a bio-RSA? Does that mean stacking the hemispherical head on a cylinder to get your lateralization? Or does that mean having a larger section of a sphere? Either way, first sort of crack at this clearly was Frankel kind of working on his own when no one believed him. And scapular notching was noted, but people weren't sure what the problems would be with scapular notching. So lots of studies showing that lateralized spheres demonstrate less notching. Then the questions become, well, is that worth it or not? Probably less instability as well. More recently, I think people understand that, yes, the Grammont, traditional Grammont style can probably work well for simple cuff arthropathy with a high riding head, good deltoid, minimal cuff. But if you're talking about a cuff intact, reversed with bad deformity, fracture, there may be some benefits in lateralization of the sphere, moving the sphere away from the glenoid. Potentially benefits in range of motion as well. This is just kind of a cartoon of it. If you have your center of rotation, typical Grammont style on the left, just sticking right there at the bone, base plate interface, maybe your tuberosities can heal potentially because they're under less tension. That's been a theory. But remember in this Grammont that you pushed your arm more inferiorly. So you do still have a lengthening of the tuberosities. They may be more medial, but you push them inferiorly. This image on the right with a more lateralized center of rotation. Concern there is that maybe it is a bit harder to get the tuberosities into the correct position. Potentially if you overstuff the sphere or the liner. But the advantage is that if you can get the appropriate tension, you may have better residual function down the line with tuberosity healing because you've got the length tension relationship of the remaining cuff and tuberosities more appropriately aligned. So risks, it does put more stress on the base plate in this particular argument. Generally, though, with modern technology and locking screws, we really don't see in our system or in my practice, we don't see a ton of base plate failures with modern designs. I think there was a fear. I mean, this early Grammont on the right side, people aren't using things much like that anymore with, just kind of flat back and not much options for locking screws. But a central screw potentially that's bicortical or a central post that's bicortical, peripheral locking screws, those have much lower failure rates than what we might have expected initially with the traditional Grammont implants, and certainly lower than an all poly glenoid. Challenges, they're still not easy. It seems easy at times if you're doing these early on. Because you say, man, my exposure is great. It's so much easier. Tuberosities out of the way. It's just like cut out some more of this. Give me plenty of room. Put in whatever base plate and sphere I want. That's going to do great. But it does get quite a bit more difficult when you actually put the stem in and the liner, getting the height appropriately positioned, and then doing the repair. So instability and dislocation was the most common reason for revision back in 2017. That is not in my practice currently. That is not what we're seeing in our region in Utah. I think modern base plates and spheres, maybe having neck shaft angles closer to 135 to 145 are helping. So instability and dislocation is still a concern, but it's not to the same level when you're dealing with Grammont only. Most common complication, basically the same thing there. But tuberosity related complications are problematic. And I think the tuberosity repair is essential. There's a number of ways to do this. Despite the fact that I've been talking about more modern implants, the stability of the reverse arthroplasty is not magic. You need to have appropriate tension. You need to repair what you can. Certainly of the posterior greater tuberosity with the infraspinatus, as well as the subscap, either on its own or with a wafer of bone. Lots of dislocations with leaving the tuberosities fly or resecting them. Clearly, tuberosity should be preserved. There's a number of techniques for that. I think that the healing of the tuberosity is quite important. It doesn't have to be complete healing, and it doesn't have to be perfectly anatomic, but definitely getting some balance between subscap and infraspinatus, super important. You can potentially, if it's tight, you can even excise or release a little bit of the supra, almost like you would if you needed to in a cup intact reverse for degenerative arthritis. But certainly getting as much of the greater, both for the deltoid wrap and for the repair of the infra and any supra you have left is really important. So here's some more cartoons of how this can work through an implant with a suture collar. Don't have to use a suture collar, and I don't currently, but this is kind of the idea. Basically, you have your three main components. You have the shaft, you have the tuberosities, and you have the implant. So at some point along this pathway in this plan, you're sort of putting in your humeral cup and then tying your sutures at the end. All of that is reasonable. Every implant's a little bit different. This is kind of like the bunion surgery part of the operation where, if you ask, Sardelli and I and Sharif, like, well, I'll say something different. And then if you come back around to us in 5 minutes, we might even get a fourth opinion. Like, there's so much on the suture and tuberosity preparation and repair that is not, this is the part of the operation that's not purely cookie cutter. And so this is the fracture fixation, and it can always be a little bit different. General principles, though, are, in my mind, each tuberosity should be prepared to the shaft, the implant, and to each other. So cerclage loop that's going sort of around the neck, that's through the greater and potentially the lesser if you've taken that with a wafer of bone, or if you've just removed that and are just using subscap only and going to get that to heal to the implant or the superior part of the shaft. I do think that cerclage suture around all the tuberosities helps. But generally in these cases, we go back one slide. I think that placing these sutures in the shaft early on is reasonable. You want to have some through the tuberosity. You're going to place this. These are tricky to press fit at times. And so you're not going to have the same gliding of your sutures when you have cement involved. So these are my principles, though. Sutures through the shaft, put some through the implant, put some through the tuberosity, and well as the cerclage. Cement the implant at your best guess at the appropriate height, somewhere 6 to 10 millimeters above the calcar fracture is often where it ends up sitting. You can use your lateral tuberosity and shaft reduction as a read, and then kind of do your knot tying after that. So here we're back to this CT that we started with. There we go. And this is how she looks. Different implant. This is more of a typical non-Grammont style lateralized sphere, 135-degree neck shaft. This is obviously the DJO at the time, or now Innovus. But so I was able to get this read laterally where the tuberosity is aligned with the shaft, distal cement, repair my tuberosities through the suture holes, and she has a decent shoulder that looks like it has a healed tuberosity. So we're happy with that. A little bit different style. This is a monoblock implant. It's not the modular that I was showing before, the J&J Unite, although I've used both. I think the key things are that you have suture holes, which is nice. You have areas you can put bone graft into if you need to. You have proximal porous coating, and it's smooth distally so that you can't cement if you need it. The problem is with this implant for press fitting, you can at times, but when you have that calcar fracture, this area right here underneath often sits just on the calcar or just above, and it tends not to be as stable as you'd like it to be without really overstuffing this portion. So the majority of the time, I'm still going to be cementing a stem like this. And to be perfectly honest, regardless of implant, most of the time I'm a believer in cement for fractures. I just think it's harder to be confident with your fixation. In the very first case that I showed, that one was press fit, but that did not have nearly as much calcar comminution, and the greater tuberosity was quite stable. So a couple different sizes here, similar ideas though: suture holes, porous coating, and this is basically the same stem that can be used for primary, reverse, but also works quite nicely for fractures. Okay, so here's that same case. She is a year out at this point and nicely healed tuberosity. So the game's fair. She should like that for a while. All right. So now we're going to push. I know you guys have some cases to show later, but we're just going to kind of push into some sequela of these operations. I mean, everyone loves reverse. It's more like a hip. Like I hear more and more, oh, it's just easier, all this stuff. So now we're going to talk about some of the things where it's not easier, and where at times you might be, wishing that someone had rolled in with a hemiarthroplasty to your office. So these aren't all periprosthetics or things like that, but just kind of post-surgical sequela. So 79-year-old female, active, pretty healthy. She has bad humeral DJD, also really narrow acromial-humeral interval, some calcific deposition there. So I discussed with her options. I don't know who we have, if this is the time to ask questions, but before I show what I did, anyone on the call thinking this is a great patient for an anatomic or a hemi? She is healthy. I'm not going to let you say she just needs another injection. And if anyone's moderating and says, no, this isn't a time for question, I'll just keep going.
Anybody want to jump in, say what they would do?
Majed, we're doing a bunch of shoulders. What do you think?
Looking at her shoulder, bad glenohumeral arthritis, a little bit of cuff arthropathy picture as well. Hamada 4B, I would consider reverse for this patient if she's failed non-op measures.
Yeah, this isn't your board exam. You can, I like surgery too. So we're going to assume for the sake of this talk that non-op measures have been appropriately attempted and not reasonable. So yeah, I think you're on the right track, Majed. I think this is a different argument. If this patient's 59, maybe you're a little bit more careful. Maybe you're getting other advanced imaging. Maybe you're really looking carefully to see, is her cuff really bad? 79-year-old for me, probably a cuff tear, maybe a little bit of residual infraspinatus there. You see that little calcific tendonitis up here, mild retroversion. I think that's a reverse for me as well, most days. So there it is, reverse, uncomplicated. It's a small shell. It's one of the smaller spheres. Things look happy. So great. We high five, get her out of her sling. She's loving life. So at 7 weeks, though, onset of pain, she's back in her sling. She has, kind of a little bit more pain with everything, even rest. Can't tolerate PT. I'm always worried about stiffness in shoulders, so I'm super worried when anyone puts themselves back into a sling. That's not a good option. She's minimal forward elevation and abduction, actively, even passively painful. So give it away here a little bit, but her incision's well healed, not having any fevers, no constitutional symptoms, and she's a little tender over the acromion. So have you seen this yet, Majed? You're working with Sharif.
Yeah, I'd be concerned for a acromion fracture.
Yeah, good concern. You probably don't see him with Sharif, though, because everything's perfectly balanced, but sometimes they do happen. So yeah, it's a problem. And it's one of the problems that in this patient, if this patient is younger, not to beat a dead horse, but, I've never seen a acromial stress fracture in anatomic. I've seen other problems, but you're kind of kicking yourself when you get this x-ray. Right here, it's just tipped down a little bit. And no matter what we do, I still think this is the best option, and I would do it again. But you have a couple percent risk of acromial stress fracture and reverse arthroplasty. Lower if the patient has glenohumeral arthritis and if they have cuff arthropathy. But you're always picking your poison. Nothing is perfect. If you do an anatomic in this woman, she won't get an acromial stress fracture, but she could tear her cuff, or her glenoid could come loose, or things like that. Or even if her implants are well fixed, she could lose the ability to actively forward elevate subscapulae. So even though we think this is most reliable, I think this is something to consider, that acromial stress fracture and reverse arthroplasty are a meaningful concern. If we're just jamming these in everyone, you're gonna have more acromial stress fractures. And the downside is these are tricky to treat. Fortunately, hers is minimally displaced. So anyone on the call interested in this x-ray and putting a couple plates on that, or other options? I'm not interested in putting plates on that. So
no. Hey, Ben.
Yeah.
Could I interrupt for just a minute and ask?
Absolutely.
Do you feel like the acromial stress fracture is more common with the Grammont or with the lateralized, or is there no difference in your experience?
Well, I do feel like it is. I do think it's common. I think at this time, this was probably 6 or 8 years ago, this was the smallest sphere, the least lateralized sphere. So this is what was called a 32-4. They make a 32-6 now. I think it's tricky because I think the data, Matt, that we all see and that probably the residents and fellows are looking at is, if they have arthritis and their cuff's intact, they're less likely to get a stress fracture, and that risk is higher if they have cuff arthropathy. But what is this? What do you call this woman? Right? She's 79. She has some cuff, some infra, but she's not as high riding. She doesn't have femoralization of the greater tuberosity. She's not a classic cuff arthropathy, but her cuff's dysfunctional. So I do think that is a little bit of a concern with overlateralizing. And if I had this patient again, I would use the smaller sphere, 32-6. Now, that being said, I have had stress fractures in 32-6s as well, and very petite women. So it's a battle. I'm trying to put these in less tight than I ever put in Grammont's. I can't remember the last dislocation I've had. I haven't had any dislocations in petite females. Usually larger males. I've had a couple over the last 10 years. So I do think it's a concern. Sardelli, I think most of the time I take that trade, though, because I think the rotation, especially internal rotation, is better in it. But yeah, in this case, probably some bad luck, and technically I put in too big a sphere. But other comments on that? It's an important topic right now.
Hey, this is Dr. Ansock, the shoulder we got here at DMC. I think the only change that I've also made for for this population is I'm a little slower with my rehab for them. For a lot of other reverses, I'm pretty aggressive. I get them out of their sling as soon as they're comfortable and start kind of letting them fly with therapy. And I think for these people who are really high risk for acromial stress fracture, I'll put them in a little pillow and let them relax for a little bit and not start therapy until I see them back around kind of around the 1 month mark. And knock on wood, I've only had one in the last couple of years, so I'd like to keep it that way.
Yeah, that's the thing. It's like they love it. They love it. They love it. They love it. And then they come in, they're like, God, my shoulder blade hurts. You know what I mean? Because they just have so pain the first few weeks. But
what's interesting, and I'll jump on what Chase said, is many of these, it's funny, if you, like you said, Ben, earlier, if you talk to any of us, we'll all say a totally different thing pretty much about every step of this case. And I think this included, because I let all mine go at 2 weeks. I mean, I let them start therapy right away. I get them out of a sling in 2 weeks. I've gone all the way from Vermont all the way to a very lateral 132.5 now. And it's just like you do enough of anything, you're going to see a complication. So I respectfully disagree with Chase a little bit in the sense that I slow them down because I don't know which ones are going to fracture and which ones aren't. I had one recently where I got a CT for preoperative planning. She already had the acromial fracture, and we fixed it. She's still arthritic, and she says her pain is gone. So her fracture pain was the issue. So I think this is one that we still don't know.
Yeah, it's a good point. And to Chase's point and yours, Sharif, like when I feel like I'm really confident that someone is at high risk, they might do fine. When I'm really worried about it for them, and I put in the smallest sphere and the thinnest liner, and I'm super careful the whole way, they might still get one. And so clearly we don't have this totally dialed. And fortunately, in most high volume practices, it's just, a couple percent, 1 to 2% of the time. So, but got to talk about it because you will see it. My normal, kind of what you guys were saying, my normal is to keep these people in a sling just for 2 weeks and just kind of do hand, wrist, and elbow, let the shoulder settle down, and then start therapy. I have not been more aggressive. I mean, I have not been more cautious with my little old ladies who are, 5 foot nothing and osteoporotic. But it is a consideration. So normally what I do in this case, back off on the motion, rest it in the sling, do more supported type exercise so they don't get a stiff hand, wrist, or elbow. And I'm not a super big proponent or even a small proponent of fixing these when they're like this. So I'm doing medical management, calcium, vitamin D. Maybe if they have known bone disease and they have an endocrinologist who can get them some synthetic PTH or something, maybe. But for the most part, let them back off. The only time these become really problematic is when that acromion dips down really far. And this is a different problem, Sardelli, as you mentioned with the Grammont, with the more lateralized neck shaft angle in the 135, 145 range. If that acromion dips down enough, it's going to impinge on the greater tuberosity. Less of a problem there with Grammont, but in a Grammont, your rotation may suffer, especially an internal rotation. So, all right, this is the least palatable sequela. So let's move on. Anyway, oh yeah, she healed. They don't love it as much, but they can get through. Someone like this, she gets through. She still raises her shoulders much better than it was before. She still can forward elevate to 135 or 40 degrees. Maybe she can't get to 150 like she could before the injury because she's gotten stiffer. But you can get people through this. So, all right, let's talk about some other sequela. So this is a patient that's referred in to me. I'm not going to say who sent it in because Sardelli knows this person. That would be unfair. But someone in Utah that both Sardelli and I know. That's a pretty large list. So So she's 72. She's, tough right out of the gate. She's really tough anxiety. She sees another surgeon in town who does mostly hand surgery, some upper extremity surgery, fracture work. And, he's trying to take good care of her because he thinks at the time that, she just kind of has, bad cuff arthropathy. Why not? Rep, tells me at the time of the referral, it's a little bit of a struggle, didn't go great. A lot of these modern base plates are really not too tricky to put in. They have really good fixation. So, okay, well, maybe we'll do a live with the guy or whatever some other time. Fast forward a couple weeks, she falls. She comes in referred to me because the guy's not sure what to do. She's no active motion. Her anxiety is even more through the roof than it was before. Crepitant. And so these are her x-rays from the outside place. So who's done more than primary arthroplasty that wants to take a shot at what looks wrong about this one? I don't want to pick on Majed anymore because he already volunteered. I don't want to be the person that just picks on the first volunteer the whole 2 hours. Anyone else? Clearly unhappy shoulder.
I don't mind. I mean, first I would want a CT just to see how much bone stock we have and what's going on
Yeah.
with that scapula or, and glenoid.
Yeah. So do you think a CT would be helpful? Like, because I do, but like, what's your best guess of what happened right here? And this may be something more for Sharif or Sardelli, but when you see this coming into your office and the rep says, hey, it was kind of a struggle, they never felt like it went great. And then the patient falls and has a pop. To me, I'm worried about fracture right out of the gate. I think that what happened, this base plate, I think any base plate that has a central screw or a long post that's intended to be bicortical, if you hear a story that the fixation wasn't great, you have to wonder about technique. And so to me, I'm worried right away that, this was too inferior or too anterior or something. And then she had a series of stress risers with additional screw holes and just kind of cracked through, right? So if this long central screw or your long post is not down the pipe and bicortical into the ball, you're at risk here. All right.
So Majed, look at what X-ray are we looking at on the left? What X-ray are we looking at on the right?
Scap Y on the right, templar crash, I think.
Sure. So should I be seeing a circle on my Grashy?
No, of course not. I'm concerned
Okay.
for fracture. That's why I wanted the CT to see what the bone stock is, what broke, and where. So
Yeah. But just sometimes, for the residents on the call, it's like dummy it down. Like I'm looking at an AP.
I
I
see. Okay,
should see a circle. I should see the.
correct.
Okay.
So it's tricky, right? And so imaging is tough. I did have a CT, and I can tell you, Majed, that there's just so much scatter from these screws and from the sort of dislocated anteriorly glenosphere, as well as now the humeral implant stuck anteriorly, almost right up against the glenoid, that it's very hard to interpret even with metal suppression. So it basically just looks like like the radar with when snow's coming off the Great Lakes. That's what it looked like. Not helpful. So basically, I think we know she has to be revised. I think you're hoping that it's maybe like a, poorly done ACL, that when you go back to revise it, like the bone that you want is still there. That's what we're hoping for. And that was my suspicion just based upon how I think this thing cracked off, and that the screws themselves weren't broken. I think you have a pretty good idea that it sheared off, the anterior portion of the glenoid. So So I go in there, head and base plate are rotated anteriorly. As Sri pointed out, you can tell it on the x-ray, kind of stuck up under the coracoid. But anterior, inferior 40% of the glenoid is gone. And I think when you have that central screw or central post in the wrong spot, then some of your other screws, it's almost like you're planning for an osteotomy. You just got, 3 holes right in a row, the whole piece cracks off. There was a little bit of the fragmented glenoid, still kind of stuck to the undersurface of the base plate, to the porous coating, not much. But the posterior, 50, 60% reasonably intact. So this is what I did. It's a cemented stem. I really didn't want to revise that. And again, this is a small person. So we have some debates here. And, every time I show this case, there's always a few other things I could have done, but didn't do. But so I put in a new base plate, higher and more posteriorly, slightly larger sphere. And then because I'm more superior and more posterior than I want to be. And then I actually had to build up with an 8mm spacer on the humeral side as well. So this is an interesting philosophical discussion. I might ask Sharif or Sardelli or Chase, would they do something else? There's always a problem here when you're going back for a revision for a fracture instability of, which side of the joint do you build up, or both. Clearly I built up more on the humerus than on the sphere. So anyone want to talk about what they might have done there, or if they favor one side or the other?
I think you did.
Hey, Ben.
Go.
Oh,
Yeah.
sorry.
Go ahead,
I
Matt.
just want to semantics before we get into technique. Ben, did you single stage this? Because when you showed that X-ray and you talked about there being a struggle, and it's nice that the reps kind of communicate that stuff to you, because I think that can be helpful. Did you consider a spacer and stage this?
I did. I was prepared to do that for sure,
Okay.
Matt, and that's a good. I think, I maybe glossed over that. In for some of the younger surgeons on the call, but yeah, I think you have to be prepared to go into this case to take out the sphere and the screws, graft it, and leave a hemi or something like that. I didn't think it was infected. I did take pictures, but I think I did this because I had adequate bone, but you don't know that until you're in there in a case like this with a poor quality CT. And I'll show you some, this has been bouncing around for a while, and I'll show you some other x-rays that show her getting some HO. But yeah, that's a good point, Matt. So you have to be prepared to, even if it's not infected, to leave that stem, maybe put a hemi adapter on it, maybe do some grafting of the glenoid, and come back a few months later to put in your final base plate. So when you're planning these cases, when you don't have great imaging, have all the stuff available that you can think of. Thanks for mentioning that.
Yep. Sharif, I'm sorry I interrupted you.
No worries. I think, Ben, what you got to do here, it looks great. So I think you got to find bone. And if you find that you have to go just a little bit higher, especially with something like this, where you have more lateralization off your glenoid, you're probably not going to get too much notching, but at the same time, you got to stabilize it. So I think here you have to pick your poison. You could have gone more on the glenoid side, but then we're probably risking a spine fracture if we go too far lateral and really push it with the glenoid side. So I think a little bit of both is helpful.
Yeah, I think in retrospect, you guys still see my slides there?
Yeah.
Okay, good. I think in retrospect, if she was slightly larger, she was small. She's a small, Scottish person, not great bone. She actually went back to Scotland, so that was kind of good. But she putting a 36 to build up a little bit more and take up more of that volume. That's always one of my first thoughts when you have a revision or something's unstable, is more volume, not just lateralizing or a spacer on the humeral side, but the only way to get more volume all the way around your sphere is a larger sphere. I just was super worried about getting a 36 into this woman. That's a 32. It just looked gigantic. Maybe I should have done it because I still needed the spacer. Maybe she wouldn't have gotten a fracture or not. And I'll show you why she didn't get a fracture here shortly, Sharif, because like look at all this HO. Like she's so stiff. I mean, even at 3 months, she has a stable joint. So when she doesn't have a loose piece of metal on her shoulder, but her forward elevation is 110, right? And you can see all that HO on the anterior glenoid, where she, and here where she had that base plate rattling around, and she's starting to get some inferiorly as well. And so, unfortunately for her, she ended up being probably too stiff to really load that acromion enough to get a stress fracture. So she did fine, stable shoulder, tough problem. Did not cure her crippling anxiety with this operation, unfortunately. So, all right. Here's another one. I think this might be, we're getting close to the last case for this section. So she's 84. She had uncomplicated reverse for cuff arthropathy when she was 80 or 81, I believe. So this is this is like her 1 year post-op that a partner of mine had. So that's the Unite 135. This was before the newer spheres came out that he had done. So that's just like the standard hemisphere. So she was loving it, not complaining. No complaints until she has a fall. She actually rested at home for a couple weeks. Was going back to the gym. I mean, this is a tough woman. Going to her Zumba and stuff with her arm in a sling, not using that side. Her left arm felt unstable. She went back to my partner about 3 weeks after that injury, and then he sent her to me. So how about that? Anyone of the
first question? How is she doing Zumba? How is she doing Zumba?
But I think she put her arm in the sling and she could do everything she wanted. I think it might have been like not quite bouncing around as much. She wasn't hitting the kettlebells quite as hard, less on the circuit training as well. But yeah,
there you go.
It was like 2 weeks off, back to the gym, and then when it felt like her arm was going to fall off, she came back into the office. It's awesome.
Fantastic.
Yeah. So, I think I'll just point out a couple things that maybe you can't see on the monitor. I think at first blush, you're thinking, oh man, wouldn't it just be great to get that thing to here in a Sarmiento? My concern, and I'll point it out if you can't see it, but she has a crack in the grater. And if you look, and her implant has subsided. So nice looking implant right there. And now she has a crack in the grater and it's subsided. So my concern right there, as far as non-op treatment, which I'm potentially open to any time that the implant's stable, I'm not convinced that is stable. So anyone want to discuss that as an option, non-op treatment? Because you can definitely quibble and say, she's got a displaced tuberosity, Sarmiento around the shaft. She's 84, see how she does. No takers. Okay. People want surgery. Good. Okay. So this one's tough. So does anyone, I don't know how far in the weeds we want to get here. Some of the fellows maybe. So I'll tell you that's J&J. You know what the sphere sizes are for DePuy? This is the Unite stem. Do you know what the sizes of those spheres are?
38 and 42.
I thought you might remember, Sharif. Does anyone care to hazard why I asked that? And if not, I'll just tell you. I asked that because not a lot of other companies have 38 and 42. So you can mix match different stems quite frequently on a 36, for instance, because DJO and Stryker and a bunch of companies make 36. Not so much here. So, any thoughts, like what to do here before I show what I did? Let's just say she's been doing great. She has no infection, and we have decent confidence that that base plate is stable. She's got some other X-rays as well. Anyone want to pitch an idea?
You can remove the stem should be unstable, so you could pull it out, and then cement a new step in ORF the humerus, and bypass that fracture to cortical widths distally. Where the other option would be to do a total humerus.
Yeah. So yeah, I'll tell you, we're gonna take total humerus off the plate there. So you're saying long stem and then like cerclage. So you're talking about like a 170 or 200 millimeter stem cerclage around the fracture there.
Correct.
Yeah, definitely reasonable option. Anyone just want to leave it? Anyone not as worried about that greater tuberosity as I am and think they can get the thing to heal in the Sarmiento? Not really. Okay. So I think you said the two standard option, Michelle, no problem. I don't think that the total humerus is a great idea personally. I think that long stem is pretty reasonable. I ended up not doing that, and I think you can go longer or shorter with these. And so what I did was, you're right, the stem fell right out, but I just plated the fracture below and then cemented the shorty above it, because I thought that that was going to give me the most reliable way to heal that long oblique fracture. With the diffuse stem, you don't have, I mean, all of these stems, apart from maybe some of the newer things from FX or, maybe the Stryker Revive, unless you have some splines distally, it can be hard to control that rotation that far distally. Not that it's the wrong answer. It's still definitely an appropriate answer to do a long stem and try to cerclage it. But I do worry about the rotational stability. And so for me, I just opened up her arm completely, took out the stem, plated it, and then put the short stem above. So comments on that? Obviously it's in a talk, so she loved it. You only should put things in talks that do well. But Sharif or Matt, I think the key thing is just, fixing the fracture and getting a functioning implant again, kind of however you have to do it.
No, this looks great. I mean, the subsidence was a big thing. Obviously, you got to give her a stable implant, and this looks great.
Yeah, that. I think plating the fracture was the right answer, Ben, as opposed to a really long stem. This is a much more reliable way to heal that.
And I think that the longer stem, like I mentioned, Stryker, you end up going down the rabbit hole with that too. If you have a stem that has the distal splines, so you have that fixation distally for rotational control, then you're worried about, well, can I mate that off label with these spheres, and when you have a 38 sphere and then you say, okay, I'm going to use the long Stryker stems. I mean, I have to get the appropriate sphere. I have to pull a base plate so I can go to a 36. There's just a lot of things kind of stacked against me on this one, so I plated it. That's all I have for this one. Do you guys, take a break or grab a coffee, or what's your habit?
Yeah, we can take a 5-minute break. What do you think? 5-10 minute break? Does that work for you?
Sure.
Yeah.
That'd be great.
Great.
Perfect.
Yeah, sure. Go
Okay.
for it.
Awesome. So, case presentation I did with Dr. Bichet for today's kind of lectures, just kind of something to go over.
So the case that I'm talking about is a 16-year-old female. She has bilateral shoulder instability with greater than 50 documented dislocations on each side. On her right side, she had shoulder arthroscopy with an anterior glenoid reconstruction with distal tibia allograft, remplissage and infraspinatus tenodesis, and labral repair and capsularrhaphy on July 15th of 2025. So this is on her right shoulder, and this is just a few months ago where she had her procedure done by Dr. Bichet. Her right side is doing great. On her past medical history, DVT and a seizure disorder, which is kind of something of emphasis just because it's one of the reasons, obviously, she's having all these dislocations and why there's so much kind of to think through and go through when stabilizing her shoulder. So most recently on October 20th, her left shoulder redislocated, and this time was have to be reduced in the emergency department, and she's continuing to have pain and instability. Sometimes it would spontaneously reduce, sometimes she'd have to go to the ED, and this most recent one is where she's having more pain and instability was requiring a close reduction in the emergency department. So she was seen again in the clinic. She has no alignment, no misalignment, no scapular winging, no AC prominence. There's no tenderness to palpation to soft tissues or bony structures. Her active range of motion appears slightly limited, most likely due to pain and instability for someone her age. So her forward flexion is 120, external rotation at 0 was 40, external rotation at 90 was -20, and she could only get to her PSIS with internal rotation. And then internal rotation with 90 degrees of abduction was -80, and she had a painful arc, which is important. So the whole time she's moving, she's in pain. Her forward flexion passively was 130. Her stability tests were positive, increased laxity, positive anterior relocation test, positive apprehension, and positive anterior load and shift test. Her special tests, Hawkins, Neers, O'Brien speeds, and MTK were all negative, and she had good strength. So again, she has the dislocations. She's painful. She required another close reduction. So she's doing well on the right side. So it's time kind of to consider doing something on her left side. So you get x-rays in the office, and you could see very, very, very large Hill-Sachs lesion. Again, it makes sense due to the number of dislocations and her continued instability. So you could see your scap Y right there. So again, kind of to ask some of the residents, what's the next step of imaging? What would you get? If anybody wants to kind of chime in.
Can I ask one question before they talk about imaging? I mean, does she have any other reason besides the seizure disorder? I mean, she seems like, does she have Ehlers-Danlos? Has she been worked up for that? Or is this mainly just due to an uncontrolled seizure?
Yeah, her Baton's is 2 of 9. So she doesn't have any other things other than this ongoing seizure disorder, which continues to be a problem for her.
Thanks.
I'll just keep kind of trucking along. So
who are the residents? Who are the residents on the call? Who's the oldest resident?
I can go ahead.
Perfect.
So we have plain films, and we can see a large Hill-Sachs lesion. We can go ahead and get a CT scan to see what the version of her glenoid is like, to actually measure the size of the Hill-Sachs, although we already know it's pretty large.
I mean, why not get an MRI?
We already know the I mean, we could get an MRI, but I feel that her instability is driven by, large bony defect.
Good. That's the point, is we could get an MRI. It's not going to give us much information. We know we have a bony problem.
Correct. So obviously we get our preoperative CT, and again, you could see that large Hill-Sachs lesion, and you could see a little bit of hyperdensity to the anterior glenoid due to the repeated dislocations. So again, going back to her seizure disorder, so we're planning for surgery, and she has everything under control. However, unfortunately, due to we're just 1 week prior to her surgery, she has another seizure. We reached out to neurology, and they're like, do the surgery, and we'll continue working her up, or like treating her medically, and hopefully get it under control. So that
you guys have different neurologists than I do. usually our anesthesia docs are like, yeah, anesthesia is the cure for all seizures. And the neurologists are like, yeah, but when they wake up, they're going to seize. Don't do it. Anyway, tough spot. Sharif, you're the man for the job.
So we take her back to the OR after being cleared. She gets anterior glenoid reconstruction with distal tibia allograft. She has remplissage with infraspinatus tenodesis and a labral repair and a capsulography. So we're doing a lot of the similar procedures to her right side, which is now stable and doing well. So just some intra-op photos. You could see the large Hill-Sachs lesion, how much bone she's actually missing off of her humeral head. There's that picture on the left. And then on the right, you could see the elevated capsule off of her anterior glenoid and all the damage that's done to her glenoid due to the repeated dislocations. Continuing with the photos, just getting, I have a video coming up with the help of Dr. Bichet, which kind of goes over it in detail. But you could see the distal tibia allograft. It's well lined up. The cartilage surfaces are at the same level. And then you could see the inferior capsular capsulography and the labral repair and everything kind of pulled up and tightened. And we're trying to kind of recenter that humeral head over that glenoid. So this is a procedure. Hopefully it shows perfect. So this is we start off with elevating some of that capsule off of the anterior glenoid, off of that eventually gets tagged. That stitch is kind of used to help control that soft tissue in the front. The bony block is then cut in the back table. Everything, the subscap is split, so you're able to bring that in.
No subscap split. This is the interval. And
Oh,
that
yes.
was the remplissage. So no subscap split on these. On the latter J's, yes.
Correct. Sorry about that. And then you could kind of see the bony block getting lined up, and that was also prepped and prepared. So once that was all lined up, it was drilled and the screws were placed. You get good compression with your screws. We'll talk about fixation in just a second. And then this is everything, kind of the capsule, labrum, all kind of brought up and repaired to kind of give more anterior stability. You want to give this patient as much of a chance to have a stable shoulder as possible due to her age, her disorder. Not many options afterwards. Kind of that last picture, just show you guys real quick, just looking at the humeral head and the glenoid and how it's pretty well centered and it's kind of returned to its normal position. So she came back.
You did those front to back or back to front, those screws?
Front to back.
Okay.
You could see her post-op imaging on the 11th. She came back. Everything is well positioned.
If anything, you can see she's at probably a little further posterior on the scap Y, which is fine with me.
Looks really good. The plan for her post-operative after first appointment was sling for 6 weeks, daily elbow and hand wrist exercises. You begin her therapy at the 4-week mark, and then she's gonna follow up for 4 weeks. So she should have an appointment coming up, I think, this week. Hopefully, she's doing well. So, a few things to kind of discuss and talk about again with the assist of Dr. Bichet. So, looking at these bone blocks, we actually recently had a procedure where we looked back at a patient that had a posterior. Had a bone block done, but it was almost looked normal to me for somebody obviously that hasn't done that many of these. I looked at it and like that looks more like a native glenoid and everything kind of remodeled and looks more anatomic or more normal. And this study kind of shows you that with CT analysis, the glenoid kind of returns and remodels to its normal shape at 6.9 months post-operatively. So that was kind of really cool to see clinically, as well as this paper kind of showing you how everything kind of comes back to normal native glenoid size and architecture, and even the shape of it becomes more normal. You don't have just that bone block sticking out in the front or the back. As for fixation, we did the screws. However, you could do buttons or cerclage wire. Looking at the data, though, there's a higher failure rate with buttons. 39% failed in the button group and had recurrent instability. And that 39% had to have revision surgery. For the screw group, when you have your fixation with the bone piece, sometimes you do have to remove the screws, which in this study was 11%. However, that bone block had healed, and you never had to revise those patients. So there is a higher resorption rate as well as higher failure rate for the grafts with patients that have button fixation. So that's something to note. And the reason that's something to consider is because of the seizure disorder. And, you know, you don't want to risk the patient breaking her screws or having, issues with the hardware. However, we really wanted to restore her stability and make sure that bone block heals and she has larger tracks for the Hill sacks not to engage. So it goes from a, off track to, or on track to an off track lesion. Then looking at this study for the cerclage fiber tape with remplissage, this was a study in 2020 to 2022. It was a smaller study, 10 patients. They followed them up for a minimum of 12 months, and the graft loosened in 30% of those patients and had a higher rate of migration. So again, 30% for the cerclage, 39% for the button, and then 11% for the screws. So the screws do have a higher risk, of fracture. However, we just wanted to make sure that bone block did heal. So those are the considerations for fixation type for her distal tibia allograft. Bone block options, you could again use distal tibia allograft, fresh or frozen, iliac crest autograft, distal clavicle autograft, distal radius allograft, and then scapular spine autograft. So those are all the different considerations that you can kind of work with. She did have, again, we did use our distal tibia allograft. For that, you want to make sure the size is 1 by 2 to 2.5 by 1.5 centimeter. And you want to match their bone loss using preoperative CT. So you want to make sure you're restoring as much native glenoid as possible or returning it to a normal anatomy as possible. And then you want to make sure it has the same kind of the face to the glenoid isn't perfectly straight. So you want to come at an angle, line it up appropriately, and make sure the cartilage surfaces are well lined up. So sometimes when you look at x-rays post-operatively, the bone block looks off, but in reality, looking at it arthroscopically or directly, you see that the cartilage surfaces are well lined up for that patient. So the learning curve for arthroscopic Latarjet decreases after 25 cases. So in this study, 55 consecutive patients, a retrospective cohort, there was a significantly a decrease in operative time after 25 patients. You could see it, the operative time decreased from 105 to 82 minutes after the 25 cases. And the complications also went down. None of them were permanent complications. However, just something to note. So there was the first 25 had 2 screw irritations, which was resolved with screw removal, and a transient axillary nerve injury, which resolved over after follow-up. But again, those are things you don't want to be dealing with or the patient, would be anxious about. After those 25, after that learning curve, one patient had a broken graft after a fall, which was then revised to a distal tibia allograft. So arthroscopic Latarjet is a little bit more difficult of a procedure to do than a distal tibia allograft or any sort of allograft. For the arthroscopic anatomic glenoid reconstruction, the learning curve for this is shorter. It has on this paper, it says 9 patients to get appropriate glenoid reconstruction or placing your graft in the correct position. So it was showing on this, after 9 cases, it has cluster 1, 2, and 3. After the 9 cases of the first cluster, clusters 2 and 3 for the arthroscopic anatomic glenoid reconstruction, you had appropriate lower third positioning of your graft, and it kind of came together more anatomically or more in the position that you want to kind of put that bone. So again, anatomic glenoid reconstruction has a shorter learning curve than the actual arthroscopic Latarjet, and that's kind of what this patient did have. So those are all the kind of things we kind of wanted to discuss. I don't know if anybody has any questions or input, Dr. Bichet.
No, I think as well. Go ahead, Ben.
Oh, I said great case. I was going to ask you, Majid. So why? I know this is part of the talk to have a heavy push on allografts, but in your mind, when would you do this versus a Latarjet, open Latarjet, scope Latarjet? She got a big Hill sacks. You have options. You have that graft there. What are the decision points for you?
Just her age, then a small female, how much bone you need, how much you want to add. Doing a cystotibia allograft, you have you could put as much bone as you want theoretically. You don't want to harvest a ladder or coracoid in small female and then not have enough bone, anatomy or stability just because of that. Those are the things that I would consider in somebody her age alone. Bone quality and strength. You don't want to fracture in a small female, all those stuff. So that's kind of why I would lean towards distal tibia allograft in this patient.
There's a couple reasons. I think he hit most on the size, and you can measure the coracoid on your CT and figure out how much bone loss, and you can predict what you need back. And if you can't get enough back with the coracoid, then the DTA is great. And one of the biggest things about resorption, it's really more remodeling from Wolff's Law, that initially when Ivan started doing this, he would put these giant bone blocks in, and they all kind of went back like this picture here. They all went back to what a normal glenoid should look. So he realized that you can't use this just as big a piece as you want, because otherwise it starts doing this. It remodels to what it needs to be. So it's less is more, but you got to figure out what that size is in order to figure out the right piece of bone that you want, because what you're going to have otherwise is these two big screw heads, holding it there, and that's going to cause some irritation.
I'm glad you use screws. I like to use screws. I think that's a bit of a straw man argument that you have to take these out for hardware removal. My go-to is still a ladder J with screws. I've had one break, seizure patient, guy seized and broke cannulated screws. So all I did was stop using cannulated screws. But, I think there's a push for it. Screws are cheap. I'm a little bit cynical about it, but, endo buttons, there's a lot more money in it for the companies.
Mm-hmm.
There's an argument, you hear the analogy like, oh, well, they hold racing yachts together with these high tension, textiles. Fine. They don't hold airplanes together though, right? So these, textile tension bands, basically, which are endo buttons, like they're really poor in shear, right? That's why airplane rivets are solid. So you worry about this thing in shear for sure. And so I totally support the screws. I just brought up the ladder J because I have had patients with these similar problems, maybe not 50 dislocations, but, large Hill-Sachs. I feel my habit, I'm not saying that any of these are wrong. I think habit has a lot to do with it, but, a ladder J through a subscap split, and then potentially all the other things that you talked about, remplissage, what you do with the biceps, you placate the capsule. There's a lot of options with the coracoid as well, with the conjoint attached. Depends on size, of course, but that's probably my go-to still out of habit. Even though there's a great case. I do think the fixation matters. I wonder sometimes if we might be able to do better without sort of tension band buttons, but even anchors, combination screw and anchor. But screws can be a little trickier to place, but there's nothing better, especially with autograft, for getting it to heal, in my mind. So cool case. Nice job.
Thank you. Good job, Jen.
Hope she stays on the Keppra. All right. So are we back to one of my talks then?
Yes, I think we're good to go back to yours.
Hey, Ben, I'm going to get in the car, so you won't probably hear from me, but thank you. I'm going to start listening from the car.
Yeah, I'll be like your personal podcast.
Just don't put me to sleep.
We'll see. You should have more coffee. I've been up for 2 hours already, man. In a different time zone. I'm just kidding. All right, let's share here. I'm not gonna share. All right. Do you see a slide there?
Yes, sir.
Yes.
me see if I can. But there, you still see, is it full screen now?
Yes, full screen.
Okay, great. Okay, so this was sort of maybe less, a lot less clinical. This is more for residents and fellows. These are things you don't maybe think of a ton, but it's, how are you actually going to work out in the world? How do large health systems operate? What's the role of musculoskeletal care within that larger system? So that's kind of going to be the focus of this talk. So I work at Intermountain Healthcare in Utah. I'm a senior medical director for the musculoskeletal service line, which is Intermountain has kind of weird titles, like what's a service line, what's a senior medical director, but senior medical director probably makes most sense. Musculoskeletal service line for us is kind of like, it's basically a department allocation. So for us, musculoskeletal service line includes orthopedic surgery. So joint replacement of hip, knee, and shoulder. We have this allocated kind of between reconstruction and preservation. Again, that may seem a little bit artificial, to me or to anyone on this call who's doing a bunch of shoulder surgery, which is both reconstructive with bone or metal and plastic, also preservative with repairing cuffs or labral tears. But that's kind of a differentiation that we have in our system. I think it's still kind of a holdover of hip and knee, basically, where people put in metal and plastic or they try to reconstruct things. With hand, foot, and ankle trauma, we'd have rural docs. Our ortho spine surgeons actually are on what's called the neurological services service line. They have I have a counterpart there that's a neurosurgeon, and he kind of oversees the spine and operative neuro care, regardless of whether it's an ortho or a hand surgeon. Ortho or a neurosurgeon. We have primary care sports medicine. We do quite a bit with that. In our region, we have about 65 employed orthopedic surgeons, about 20 employed sports medicine docs. And we also have podiatry, which is tricky. All of us on this call understand the differences in, the level of responsibility and how much more challenging it is to get to be an orthopedic surgeon than a podiatrist. So that's always a little bit of a give and take. What's the role of a podiatrist compared to orthopedic surgeons? There's a lot of podiatrists in Utah. I'm not sure about Michigan, but I think there's a lot of them everywhere, and it can be a tricky balance. So this is just a slide to show that musculoskeletal care is a team sport. So we have a very large region. It's just about all of Utah, and if you know Utah, you might not, but Sordelli does. But southern Utah down by St. George is sort of lumped in with Las Vegas, but we have basically the rest of Utah from central Utah all the way to the north, even into southern Idaho. So it's a team sport. Brian King, he's a great colleague of mine. He's up in the northern part of our state in Logan. He's an Air Force doc. So he's our medical director for orthopedic surgery and podiatry. I have Anthony Butler, who's my medical director for primary care sports medicine. He was the past president of the basically the non-operative version of AOSSM. Yvonne Fulenbaugh is our PA. And then I have what we consider in our system these dyad relationships. That's sort of like a hot term in leadership now, as a dyad partner. So, I'm the senior medical director, and then I have a senior service line leader. His name's Ben Lane. So we got lots of Bens on the calls all the time. But he's business and operations focused, and and he has a team as well. So really, when you think about these things in large health systems, it's a team sport. If you're still coming up through the academic environment, you sort of think of, the chairman kind of has the final say, and maybe there's a vice chairman, there's a program director. As you progress into systems that are much larger than typical universities, you end up needing to have a pretty big team. So just this is sort of, some of this is just kind of boilerplate that we talk about within our own organization. So I just wanted to give you guys a little bit of a taste of how large health systems work. So this is just a little bit of the scope, and these are things that we would share with other people in our organization. Intermountain has about 75,000 employees across 6 states. So sometimes, we're trying to explain what we do to thousands of people that don't quite know. So we have 18 hospitals in our region, 40-something thousand cases in 2023, a couple 100,000 outpatient visits, 3 trauma centers. Probably in the short term, we're going to switch that so that we have 2 level 1s and only 1 level 2. In 23, we worked with over 400 providers. I mentioned the numbers that we have employed. So our surgeons, primary care docs, podiatrists, and PAs and MSK, about 150 of those are employed. Between 150 and 200 are employed with our group. And then the remainder, few hundred, are in other group practices, potentially private practice, or they have a co-affiliation. So some of our docs at the University of Utah that we're collegial with, they have also an affiliation at the Children's Hospital. So we have a lot of doctors that we work with without sort of a solid line control type relationship. So you think about it in the org chart as a dotted line. So we have a lot of folks that we have to work with kind of by influence. And I would say generally in surgery, especially in orthopedic surgery and neurosurgery, but generally in surgery, you're working with influence a lot. It's all of these people that you're working with, they're highly capable and highly motivated. Very few people that make it through orthopedic training, just kind of want to do what they're told. It's a lot of self-starters and a lot of people that have strong opinions. So you're working through influence, quite a bit. By 2024, hospital cases went down a little bit, but we had more ASC partnerships. So you see that a lot. You see this a ton with hospital presidents. I don't know how you guys are organized, but hospital presidents often are thinking like, well, my margin's down. Shouldn't I just be trying to grind as much margin as I can from these, healthy commercial payers? And then we as surgeons might say, well, maybe a better position to have that procedure, that primary total knee, that total shoulder, ACL, cuff, whatever it is, ankle fracture. Maybe we should do that in a surgery center. It's lower cost for the patient, it's lower cost for the payer. It's more efficient. So we, as a large system with 19 hospitals now, we're taking a lot of our cases into ASCs, not just in ortho, endo suites, those kinds of things. I think in some areas of the country, that's further ahead. Intermountain was kind of slow to this game. Intermountain for a long time was, I think, whether or not they would say this, they were basically like a hospital and landowning company. And so having a lot of hospitals, kind of making sure that people went to those hospitals, having docs to work in those hospitals was the primary goal. Now they're starting to understand that patients want a more efficient site of care. They don't want to go to the hospital if they don't need it. We're helping push people cases into ASCs or, wide awake hand surgery, things like that. So that's kind of one of our pushes. Not all of those 27 medical group clinics you see there are doing everything. We'll talk more about that later. Not everyone can do everything, even in a large geographical area, and that can be tricky. But our full service sites would have everything from in-office, wide awake hand surgery, all specialties represented in the clinic, ASC access as well as hospital access. So on the hospital side, this was kind of a big win for us, redesigning geriatric hip and femur fracture. This is always a little bit dicey in hospital systems where sometimes the hospitalists or the pharmacists don't always want to get involved. Maybe anesthesia doesn't want to get involved. And it's tricky. I think any of us, whether you're studying for your boards or early in residency or through your boards, I think we all understand that older folks who can't get around much, they do better, probably worldwide, if they're under the care of someone who's not just solely the orthopedic surgeon in that PA. So the tricky thing is every time you go from paper to a new EMR or EMR-A to EMR-B, some of these things get lost. The upside is that it's a chance to refine these. And so we had to refine this again, most recently, this was 2024. We're doing this basically done now because we switched from a Cerner product to Epic. And so that puts in some new problems, but the combination between orthopedic surgeon, hospitalist, ED, trauma, having anesthesia, maybe go down and do fascia iliaca block in the ED, as opposed to letting the patient sit on the floor in significant pain for 12 to 24 hours, getting endocrine involved for bone health. So this is best for patients, but it takes a lot of coordinated effort. And even in a large system, we're not centrally planned as much as you think. So every time, on the team slide I showed, there's a woman, Melanie, who's in charge of our clinical initiatives. She's a nurse by training. And so she and some of our team are going to each individual hospital, talking to the medical staff, trying to convince the anesthesiologist how it's better to do blocks down in the ED when they're available, trying to get the ED to understand that, when you call for a hip fracture, it's not just one consult to ortho, it's like automatically, how do we blast out to the hospitalist, anesthesia, potentially trauma team if it's high energy? How do you get all those people involved right away? Because it's not automatic, and it's not always easy. But if we can run through these clinical practice models efficiently, really, really beneficial for all of our geriatric patients. So talked a little bit about the outpatient and the inpatient. What do we really want to do? So this is kind of our mission statement. I don't know what's fashionable in your organization, your North Star, your True North, your compass. I don't know. But this is what kind of drives us. We want high quality care by the right provider at the right time in the right place. So we're pushing for expert triage, referral, and navigation. We want to have nearly comprehensive APP strategy, which would mean skilled APPs working with surgeons, potentially seeing independent clinics as well. Moving away a little bit from a model which we might consider to be older, where you had a doc and an APP and they were just like stuck on each other's hip. And if everyone was done early, yeah, sweet, tea time at 10 a.m., let's do it. Versus maybe the APP can operate more at the top of their license, can see some patients independently, can generate new cases for the surgeon, and that they can work more as a team because we want our surgeons to be operating most of the time and not spending quite as much time in clinic. I know for Sharif and Sordell, you gotta have time on the golf course. I didn't mean to say that golfing is the problem. I just meant having the team, go home at 10 a.m. is maybe the problem.
Yes.
Yeah. Because you get into a habit. PAs, I don't know if there are any on the call, but it's variable. And I have an awesome PA. It's not like residency necessarily, though, where the APP often might say, hey, I kind of get my vacation time. If Doc's out of town, I get that vacation time. If Doc's at a meeting, I kind of get that as vacation time. So you have to be careful if you're paying these highly trained and specialized folks. You want to get them at the top of their license and not sort of turn around and find that they're on average working 28 hours a week or something. That's not always easy. There's some tough habits to break, but a well-trained APP is super useful. We want them operating at the top of their license when we can. So this is kind of how we think about our successes in musculoskeletal care. Basic, sort of intermediate, and more advanced. So a basic ortho program, you might think of, it's a little bit smaller. Might be a couple docs hanging out a shingle in private practice. In our system, it's often in a more rural area. So Burley, Idaho, or Richfield, Utah. There's not a ton there, and you need people that are willing to do a lot of different things. So in those areas, we have one, maybe two orthopedic surgeons, often fellowship trained, but having a general practice maybe a couple primary care sports docs, maybe a podiatrist. You know, they don't have a dedicated ortho operating room. They have access to PT and rehab, but it's really not embedded. They're working a lot with cross-trained nurses and techs. You know, fracture care, simple scopes, you know, a lot of hip and knee replacement. We think it's really important to have these kinds of standard protocols in all of these hospitals, whether it's a geriatric hip fracture or, you know, stop bang screening for sleep apnea, or, you know, infection prevention bundle for lower extremity arthroplasty. Those things we need to make sure that we have, but you can't have, you know, 12 fellowship trained subspecialists in every small town. And so we don't tend to have that. On the flip side, if we skip over the middle point, we skip over to the right, you know, we as a system, and this is important to me, we don't really look for, advertise, or hire, even support sort of a general, quote unquote, general orthopedist, even if they're fellowship trained, along our suburban areas or urban areas. So for us in Utah, that's about a 100-mile stretch of I-15 from just north of Ogden, Utah, down through Park City, down south of Provo to an area called Spanish Fork. It's a fairly dense population. You know, about 3/4 of the state live in that area. It includes Park City, and we really only hire fellowship trained people who have an interest in subspecialty practice. So we often want to have primary care sports med docs embedded, maybe some podiatry, which is tricky. We're trying to focus more on traditional podiatry than podiatry saying, oh, I can do the same things as an orthopedic foot and ankle surgeon. And so, you know, bring on the triple arthrodesis and, you know, bring on the total ankle. We don't really hire those people if we can help it. You know, we're trying to hire more traditional podiatrists for forefoot surgery, wound care, nail care, things like that, and leaving our highly trained, fellowship trained subspecialists in orthopedic foot and ankle and fracture surgery to the larger cases. So, you know, robotic and enabling technology, that's a hot topic. A lot of marketing there, obviously, a lot pushed by Stryker. You know, at what point, when you know the margin is worse, at what point do you put a robot in every small hospital versus try to funnel some cases to medium and larger hospitals that do a great job? The problem for some community hospitals is all the total hips or knees they're doing should probably be done in an ASC in a more urban environment for better cost of care, more efficient for the docs, more efficient for the patient, and cheaper. So those are tricky. Nurse navigators or total joint nurses, those are really kind of important things for us, where every site for us that's doing total joints needs to have at least one, ideally everyone, is fellowship trained for doing hip and knee replacement, and that we have nurse navigators, which help with pre-op education. They teach classes periodically for what the patients can expect for hip and knee, and in some cases, shoulder arthroplasty as well. So our operations are kind of focused twofold: how we interact with the hospitals and how we interact with the medical group. Medical group in our case is that larger group of docs that employed, where we focus on recruiting, onboarding, you know, preferred clinic hours, which is when we think, hey, you know what, maybe we can try to have some people staying late. We can have some people actually working Friday, maybe Saturday morning, all the things that are important for healthy practices, but maybe a little bit trickier for docs that are, you know, entrenched in their typical schedule. In the hospital, presidents and ASCs, you know, we're trying to transition those cases to the proper site of care, as well as moving some of those cases out of the ASC that are hand cases into the office, so that we can do potentially higher margin for the center, but also lower cost for the payer and the patient in the ASC, like a lot of arthroplasty and spine. This is really hard, this robotics assessment and recruitment. Hospital administrators don't always understand, or finance people, they don't always understand what we do. And so to them, there's not always a ton in the playbook. It's sort of like, let's get some more ORs open. Let's get a couple robots, and let's get a general ortho doc to do some ACLs, some total knees, some hip fractures, maybe some hips, just kind of anything that's good for the hospital. So the hospital administrators and finance people don't often share the vision that we have of trying to have multiple subspecialty people at a given site to provide care for that community. So that's always a bit of a balance, especially with how much robotic access is driving thoracic surgery and general surgery. Sometimes it's an uphill battle for us to say, no, you can't just do robotic total knees in every little podunk town and not do any other kind of orthopedics and not have established referral patterns. It can be tricky.
I think, Ben, that exchange you just mentioned is probably one of the most difficult questions when you meet with hospital leadership. I think they like the shiny new toy, and essentially we're trying to take care of communities. And so that does mean sometimes, hey, what we really need in this particular group in this town is a podiatrist. We really need a podiatrist because we're bleeding out foot care that's basic. We don't need another person putting in a robotic knee. I think that bears mentioning.
For sure. And I appreciate that, because I think you maybe saw what my next slide was going to be on how we try to do that. But this is basically like we're pushing deep subspecialization. I don't know what your environment is like. I think I remember that in Minnesota, not a ton of people did fellowships, but in like Michigan, Ohio, a lot of other areas, a lot of people are doing fellowships currently. So I think that's the standard, honestly. I mean, I think that doing a fellowship, not that, I took level 1 call for years, actually, until last year. So not that I can't take level 1 call because I did a shoulder fellowship, but trying to make sure that you're the referring site if you're a shoulder fellow for all things shoulder. Not that you can't do some of those other things, but as you get busier, maybe you're pushing your knee stuff to someone that does it, everything knee and those kinds of things. So we're actually trying to base this more around joints in the body, maybe a little bit more Australian or European model, as opposed to what I would consider, which has been very common in North America for a long time, but we're trying to go away from a little bit of, I have people that, put scopes in all kinds of joints versus people that replace joints. That we're trying to go away from and have people be more focused on, 1 to 2 joints. So this is how, for hip and knee, kind of as Sardelli mentioned, when we're saying not everyone should just be throwing in knees everywhere because the margin's okay. So we have some criteria, pretty established criteria. And one of the people that's been leading on this, Sardelli, you probably remember, is Nate Momberger. He's our section lead for hip and knee replacement. And we have in Intermountain something called clinical programs, which are sort of the clinical best practice initiatives for the entire enterprise. So that's how we do a lot of our, education and things like that. So one of these keys is physician engagement. So there's a weekly hip and knee reconstruction meeting, not quite weekly, 40 times a year probably. Same with shoulder, hand, spine, trauma. So we expect 50% attendance at those. We expect to work with a joint coordinator who's on site, sometimes shared between an ASC and a hospital. We actually have, for total knee, a scorecard which compares complication rates and implant costs, cost of the episode, not just the implant, but cost of the episode, return to ED, DVT/PE, infection, things like that. And this has really helped, socializing this data has really helped drive down the rates. And we've been able to partner a little bit with some payers for a small incentive for those docs. It's only on knee replacement right now, not hip or shoulder. But knee replacement was the biggest, sort of the biggest target, things like the complications I mentioned and also minimizing discharge to SNF, for instance. So we have system process measures for lower extremity arthroplasty. We've adopted a lot of these for shoulder. BMI under 45, that hemoglobin A1C is drifting down. It's still 8, but a lot of us are looking at 7.5. And then smoking's tricky because, smoking we want to stop. What do you do about Zyn or, other types of nicotine. That's tricky, but just trying to get that down, especially away from smoking and vaping. And then we have some case thresholds. We want the docs to be doing these numbers. We want them to have. We look at people's specialties and say what's their primary and their secondary specialty. So I wouldn't qualify for any kind of incentives for a knee replacement if I decide to start doing them, because my primary two things that I do are arthroscopic and open shoulder surgery. So then if I add myself on, it's like, total knees aren't that hard. They're pretty fun. Let's do some. If I start, dropping in like some low volume, like 30 knees a year or something, I'm not going to be eligible for these incentives, because the expectation is that it's a high volume surgeon, fellowship trained or grandfathered in, and in a high volume facility. So how do we recruit? We kind of talked about that, where what we're focusing on. But we have this deep subspecialization. We want interest in leadership and education or research. That's not really much different than a lot of academic centers or large groups that are non-academic, whether it be OrthoIndy or Rush or whatever the new name is of the one outside Atlanta. You need to have a little bit more than just what you do clinically. And we're trying to separate this from hospital call. So trying to get trauma surgeons focused at hospitals and having docs that take call and certainly take care of fractures, but not recruiting just because the hospital wants someone else to cover the ER. And oh, by the way, can they do some robotic knees? Like we're again, as Matt said, we're trying to focus on what the community needs. So we can hire one-offs. Here you see in 2025, we've hired a couple shoulder and elbow people, primary care sports med, time for 3 of those, ortho foot and ankle surgeon, hip and knee arthroplasty surgeon, hired one orthopedic trauma surgeon this year for a hospital and another one for next year. So that we have about across our state, just in our system, we have 4 trauma centers. 3 are level 2, 1's level 1, and we have for those 4 sites, we have 11 fellowship trained trauma surgeons. So the other option is to kind of buy or acquire a group that's highly committed. And so when you have a system like we have, which isn't like Kaiser, where you have potentially affiliate docs who have some animus towards the enterprise and affiliate docs who are very engaged with the enterprise and hospitals, and then you have employed docs you have a little bit more control over. There are times when having a group that is highly aligned already and wants to seek employment, when that makes sense. It's tough out there. I don't know exactly all of your situations in the Midwest, but academics is kind of getting squeezed with research dollars. Small private practices are getting squeezed. You end up having a choice potentially between private equity or taking out a loan, or maybe joining a larger health system. If you go private equity, or you're going to get that second bite of the apple. It's often better for older docs than younger docs. So there's a lot of concerns. Anyway, what we've been seeing here in the West is that groups of docs who we thought for years, whether it's in orthopedics, neurosurgery, cardiovascular, who we thought for years would not be very interested in working more tightly with the system or even being employed, that's changed. So this is just one example of an orthopedic group that was highly aligned, that went from being highly aligned in private practice. Highly aligned, I mean, they did 80-90% of the work in our facilities, used our PT, used our hospitals, ASCs, imaging, and we brought them on. So multiple subspecialties, added 8 surgeons, 9 APPs, most of the clinical staff. And just in the first month, the numbers were big. So, thousands of RVUs, ramp up was really quick. That's partly because they didn't really change location. They were already affiliated, close by to the hospitals and ASCs that we use. switching EMRs is always hard. There are problems with a large organization like ours. Is every time there's an update, maybe it changes your phone number to the incorrect number on the website, or maybe you can't easily rank order the places where you work, and the DTS team always lists them in alphabetical order, and that's a problem. We have a hospital called American Fork. If anyone works there and it comes up first, because they have privileges there, but they don't actually work there very often, it's tricky. So I'm not sugarcoating it. Large organizations have different problems, but we are able to provide some security in ways to some of these groups that were feeling some other pressure for staffing and inflationary costs after the pandemic, things like that. So mainly we try to build specialization from the ground up or through acquisition, and we try to keep track of what we have in a community, both in the highly aligned affiliate and the employed side. And at times like this example, we push people over from one side to the other if they're interested. It's hard though. Big organizations are tough. There's a lot of handoffs, say, when you're being hired. And this isn't just for us. This is any of you listening with a new job. You got to have your license in that state. You got to prove you're a resident. Your onboarding person may not be the person who hired you. So you may work with a recruiter, and then that baton gets passed to someone else. And then, or you're onboarding, and it can be a really tricky process. There's a lot of scrutiny on healthcare, and large organizations have big targets on their backs in case they do things improperly. So all of these little things of like, what's your access or your provisions for your software that you have to use? What is your actual job title? How much you're going to make? What is your method of getting off of your initial contract onto something that's more production based? How do you know how to use the medical record? Even if you've used the medical record before, do you still have to do training because they're using a different instance at your new facility than what you had used in fellowship? All these things are potentially painful, and they can be more painful than you think. Early on, you're probably well adapted to it. It's no different than going from med school A to residency B to fellowship X. You're used to change. Once you're in one place for 5 or 10 years, and then you start switching all these things, it can be pretty challenging mid-career. So you have to think about that, of those costs of change if you change an employment agreement or arrangement. I talked about most of this. I did want to highlight this. So this is an example of our total joint program. So we have a fairly high prevalence of Spanish-speaking patients in this area. These joint education classes are great. They've decreased the odds of return to the ED within 30 days by over 10%, about 13%. Being Spanish-speaking is the opposite. It's just harder to get information. We have a lot of good work with interpreters in our communities and in our facilities, but it's really tricky calling over the phone with a problem after a joint replacement and then having a family member try to translate. It's just a lot harder. And so what ends up happening is docs, APPs end up saying, hey, why don't you just come in, or maybe it's on the weekend so the patient can't, they go to the ED. So as we all know, those return to ED numbers are tracked nationally by CMS and also individually by our hospitals. A lot of hospital scorecards track that. So we don't want someone, regardless of their native language, to end up in the ED because they're not sure if they should still be constipated after their total hip. That's bad for everyone. It's expensive and inconvenient for the patient, makes the mattress looks bad, clogs up the ED. So this team here, who are our joint coordinators and have been doing a lot in English, they actually worked and translated the joint education classes into Spanish, and they're taught by a Spanish speaker, typically a native Spanish speaker, which makes the patients feel a lot more comfortable with some of the different accents and dialects. So this was a big win. They actually presented this to the National Association of Orthopedic Nurses this spring. And this is a really exciting thing. So one of the advantages a large system can provide is kind of look at this population approach to what's kind of a commodity operation. We know we have great surgeons, but if we're not getting good instruction to our patients, they're at higher risk. So best practices and standards, we're kind of getting near the end here a little bit. Basically, be open when you take a job, be open to non-traditional things. Patients want other stuff. 8 to 4, Monday through Thursday, sort of the traditional, 90s, 2000s, 2010s even. It's harder and harder. Patients want things like that are not necessarily easy for us. They want to be able to schedule online directly. We think that's not a great idea for surgical subspecialists, but maybe it is for primary care sports medicine. We think that maybe we do need to have people that can meet with patients as much as we can after school, after work, Saturday morning. So these are not always the most popular times for mid-career and late career surgeons, but if you're looking for a job, I think you may be surprised how busy you can be if you're willing to see clinic on Friday, or if you're willing to operate in an ASC, say in the morning on Tuesday, and then do a clinic from whatever, noon to 6. It's pretty amazing how much patients now are looking for that kind of thing. And sometimes your staff is not always your best friend. It may not be your direct staff who's fielding these calls, but if someone calls your site, this yes campaign, you're looking for people to say yes and make it happen, right? So that can be sharing within a group. So if you're booked out but you have a colleague that does whatever operation the patient's calling about, you can't see it, try to keep that person on your campus, once they call in, try not to let them get away if you have a fairly fully fledged group. So some hiring, let's look at this one. We're getting close to the end here and I want to leave time for questions, but basically, we are looking to expand our footprint like anyone is. So we're looking at our directed lives. Those are sort of lives that by insurance plan are directed to our facilities. Looking at semi-directed, which is, we're one of a few choices that they have, but they like us. We would look to expand to out-of-network payers, right? And so depending on where you may end up working, you may have multiple insurance plans in the market, and they may not all be able to work at a given hospital. So figuring out how you can get access to those patients by potentially operating at multiple sites, or working with a group to say, hey, we provide a lot here. We're a solid multi-specialty group in orthopedics. Let's see if we can make ourselves appealing to some other payers that we traditionally haven't worked with. And then these are sort of the last things that we can discuss. So from a service line or kind of a department standpoint, how do we work with our local HR people and operations, right? They always have different concerns. We need them. They support us. HR has different concerns on what's legal. Operations has different concerns on staffing metrics and how much help do you get and when do you get an MA or 2 MAs, or when do you get your APP or your second APP? This onboarding thing I mentioned before, when you're either jumping on as a single provider or as a group, this is really tricky and you can lose some people. I had some people in cardiovascular where anytime within the Workday software, which is for hiring, anytime a job is filled, anyone else who had applied for that job gets an email saying, sorry, we're not interested. Sometimes you unknowingly lose candidates if you don't know that problem, because you may have 2 people apply for the same job, but you have a few spots for them. You might want to move them around. And as soon as one person accepts one, the other people get notified that they're not, there's not much interest in them anymore. So there's a lot of blindness in these large organizations or even smaller organizations where HR and hiring don't really know what operations is doing, and they may not know what the surgeons are doing, and that's tricky. Do you work with recruiting established or new providers? And if you are a new or established provider, what do you do when you're trying to, shift locations? My goal is to maximize provider satisfaction, which, and engagement and their productivity. Busy docs who are engaged tend to be happier. If you're spending all your time complaining that you don't have patients, you don't have places to work, you can't get the call you want, or you have too much call, that's really hard. So docs are the lifeblood of any hospital. We need to work well with our nurses and APPs, and we need to be engaged. There's really no substitute. There's no way to legislate having engaged and productive docs. So you have to build programs around them that help that. So that's 7:05. Definitely have a little bit of time for comments or things. Sharif said that he jumped off, I think, which is fine. But any questions or comments, or people want to know what they should avoid?
Ben, I thought that was a great talk. I'm still here. I sort of built this, or I guess led you to give these two talks because I wanted everyone to see what a great shoulder surgeon you were, number one. So great talk on reverse. But more importantly, I think everybody on this call, irrespective of if you're a resident or a fellow or a nurse practitioner or a PA, I think you have to understand that the work that Dr. Widmer is doing through Intermountain Healthcare mirrors the work that's being done in our state of Michigan or anywhere else across the country, in that most hospitals are trying to build service lines. Most of you are going to, at some point, have to pick a job, and sometimes that's going to be employed, sometimes that's going to be private practice. And I think either you become an employed physician and you work within a model such as the Intermountain Healthcare model, or if you're in private practice, you're still going to have to engage with your hospital leadership, because at the end of the day, most of us are doing a portion of our work at a hospital. And so understanding your hospital's culture, and more importantly, how you can engage with the hospital when you're in private practice to make sure that you're playing on the same team. I've found in my career that's kind of spanned from group practice to solo practice to working with McLaren to working with Henry Ford to now working with both to now joining another private group that's becoming more aligned. I'd like to say that I've learned a lot, and all of Ben's slides are important because what the hospital leadership is trying to do sometimes doesn't really mesh with what you're trying to do in your career or how you're trying to take care of the community where you have an office. And so having open dialogue with your hospital to say, like, that's great, and I want to work with you, and I understand you're trying to build a service line in this community. Here's my take on the best way to provide care. Those are the conversations that physicians are going to increasingly find themselves in, and should find themselves in if they're partnering truly. So I thought this was a great talk, Ben. And again, it spans the needs for those looking for their first job to those that are perhaps mid-career and looking to see the direction that they'd like to take their career in, or even end of career folks who might be on this call and saying, yeah, that makes sense. I've been part of this system for a long time, and I've been able to help and shape the department that I'm in. So thanks so much.
Of course. Other thoughts? People have questions? I think go ahead. I do have one comment to leave with people. I think you'll hear at times, you go to fellowship training things, or you go places and you'll hear, oh, here's how much you're worth to a hospital, and you have this multiple, and like you take what you collect, and you're probably worth 7 or 8 times that to the hospital. And some people take varying conclusions from that. And I've actually been at meetings where people, respected people in shoulder surgery are kind of telling the fellows to, like, demand what's yours because no one else can do it. I got to tell you, that's not entirely true, right? There are a finite amount of orthopedic surgeons, but you can really kind of dirty the well pretty quickly if you show up somewhere and start stomping your foot at the OR front desk and making demands of what they're going to provide you. Because I can promise you throughout this country, there are areas where there's plenty of orthopedic surgeons and there are areas where there aren't so many. And maybe you can get away with that in a smaller area. Maybe you say, hey, without me, you're not going to be able to replace these volumes. But generally, this is a team sport. I can promise you that when I post a job for orthopedic surgeon, I will usually have dozens of applicants. You know what I don't have dozens of applicants for is X-ray techs, PSRs, MAs. It's like we have to be reasonable to the people around us, especially if we live in desirable markets, because the old days of like stomping your feet, throwing instruments, demanding two of the newest robots, I just don't think it works. The labor market's tight. Everyone is squeezed on margin and a number of other things. And we have to understand that, we're part of this musculoskeletal team and we are an important part. We're doing the surgery, but you have to work with everyone around you really pretty carefully. Making sort of demands or ultimatums of the people in your OR or in your clinic, I think that tends not to be the best way to get what you need.
Ben, thank you. I'm going to sign off as well. I appreciate your time. It's good to talk to you or see you, and I hope we get to see each other in person, my man.
Oh, yeah. Awesome. Have a good day. Thanks, Matt.
Thank you.
Got it.
Dr. Widmer, just a question for you. My name is E.J. Rozek. I work here at the Orthopedic and Sports Medicine Department. You kind of answered my question about staffing. You obviously have a very large organization. I was wondering about your staffing in terms of just people, right? I mean, it's a problem across a lot of organizations, not just healthcare in terms of staffing. But it seems you've done a good job with working with the hospital for a recruitment plan of physicians. Are you guys always looking to improve that process, or how do you do that? I mean, it seems like
we have when we're hiring for our group, we have there's kind of three people involved. There's what we call the medical group operators. So the Intermountain Medical Group is a multi-specialty group of everyone from rheumatologists, orthopedic surgeons to neurosurgeons and everything in between, APPs. So they're sort of the administrators and operators of all of the outpatient spaces, right? So typically we as a service line, and that's where it gets tricky, is we go to a hospital and we say, okay, we in the medical group agree that what this group needs is, a foot and ankle surgeon, orthopedic trained foot and ankle surgeon. And the hospital says, well, if they're going to be in my hospital, can't we get a hip and knee surgeon that's doing a bunch of totals? You know what I mean?
Yeah.
And so I don't mean to sugarcoat it, but these are tough conversations, right? The other tough one that you always run into is you go to a group of, say, 8 docs. They want help. They feel like they're busy. But none of them want anything that's going to do what they do. Right?
Yeah.
So it's like, well, we can't just all hire a hand surgeon that's only going to do elbow, right? We're not going to do that. It's like whoever we hire is also going to end up doing some carpal tunnels and some wrist fractures. So yeah, it's always kind of a negotiation. We have the advantage of having a ton of applicants typically, in a desirable place to live, or whether it's people that want to come back or they like the outdoors or whatever. Intermountain's very stable, and the pay, the sort of the compensation and benefits are pretty transparent, which makes it appealing. So that's on the medical staffing. As far as the staff that supports the docs, that's where it gets a little trickier. We have our medical group has very, I don't want to say rigid, but like they have kind of guidelines on, what kind of productivity gets you what kind of help, right? And then we as a service line are always involved in kind of steering that, saying, hey, this is a person that's doing, they're kind of a go-getter. They're doing a lot of outpatient cases. Not a lot of those cases have a assistant code. They're ramping up in a smaller area. They might not be quite ready for an APP. But if we recruit someone that's doing a lot of shoulder surgery, a lot of hip and knee replacement, and a lot of those codes have assistant fees, and we think this person's going to ramp up quickly because they are established elsewhere, then we're going to try to shade our hiring process towards getting that person more help a little bit earlier, right? So yeah, it's always a dance. I mean, nothing moves super quickly in a huge organization, but I think that's kind of our role of this service line or department is to kind of work with the operators that kind of work in silos, you know, and try to get the hospital operators and the ambulatory operators, you know, to understand how, you know, what we're doing can work for both of them.
Great, thank you.
Yeah, of course.
Any other questions for Dr. Widmer? All right. I know you have
Great.
things to do, Dr. Widmer. We really appreciate your time. Thank you for coming to talk to all of us today. Your talks
Of
were
course.
great.
Great. Have a great day, everyone. Thank you. Thanks for the opportunity.
Thank you again. Take care.
Bye.
Bye-bye.
Thank you.